The final presentation is by Dr. Dev Paul. Dr. Paul is a breast oncologist at the U.S. Oncology and Rocky Mountain Cancer Center in Denver, Colorado. Dr. Paul.
Thank you. I'll be presenting results of a phase 2 study looking at letrozole plus dasatinib versus letrozole in patients with metastatic breast cancer. I have no disclosures, and other author disclosures are listed on this slide. SRC is a pleiotropic non-receptor tyrosine kinase involved in breast cancer invasion, proliferation, and survival. It also regulates osteoclast-mediated bone turnover. This pathway is a little complicated. SRC is in the oval yellow circles here on this diagram, but basically SRC activation involves transcription, DNA synthesis, proliferation, and breast cancer cell survival. Dasatinib is an oral ATP competitive inhibitor that affects many molecules, but also SRC. Dasatinib's FDA approved for CML, a type of leukemia, and 100 milligrams a day of dasatinib is safe and effective in CML. Our hypothesis was combined letrozole plus dasatinib as first-line aromatase inhibitor treatment for metastatic breast cancer will improve clinical benefit rate and progression-free survival with letrozole as a randomized concurrent control arm. Our primary objective was clinical benefit rate, which is the sum of the complete responders plus partial responders, plus patients with stable disease for greater than or equal to 6 months. Secondary objectives included progression-free survival and changes in bone mineral density as well as toxicity. This is a phase 2 non-comparative parallel group randomized study with a 1-to-1 randomization. 120 patients were enrolled on study, and patients were stratified by disease-free interval less than or equal to 2 years versus greater than 2 years, and prior tamoxifen versus no prior tamoxifen. This actually represents the final analysis of this data that was performed in October 2015. The women were postmenopausal, estrogen receptor positive, and HER2 negative for this study. Previous aromatase inhibitor therapy was allowed in the adjuvant setting, but it had to have been stopped greater than or equal to 1 year before study entry. 0 to 1 prior chemotherapies were permitted for metastatic breast cancer. No prior aromatase inhibitor was allowed for metastatic breast cancer. And basically patients were randomized to receive letrozole 2.5 milligrams POQ daily plus dasatinib at 100 milligrams POQ daily, or letrozole by itself at 2.5 milligrams POQ daily. The patients on letrozole who progressed had the option of crossing over to receive dasatinib and continue on the letrozole. Our patient characteristics are listed here, and the median age was 62. The disease-free interval was similar between the two groups at 76 and 77 months. 42% of patients on letrozole plus dasatinib and 32% of patients on letrozole presented with stage 4 disease at their initial time of diagnosis. The sites of metastatic disease and prior exposure to chemotherapy were similar between the two groups. About 60% of patients on letrozole and dasatinib and 49% of patients on letrozole were endocrine therapy naive on this study. There were no unexpected toxicities associated with dasatinib. There were no grade 4 toxicities, and basically the toxicities were as listed here. Mainly rash, fatigue. Some patients developed pleural effusion. As far as our results go, the clinical benefit rate for letrozole plus dasatinib was 71%, which was no different than the clinical benefit rate for letrozole, which was 66%. 35 patients on the letrozole arm who progressed crossed over to receive dasatinib plus letrozole, and their clinical benefit rate was 23%. However, when you look at progression-free survival, this was different between the two groups. The letrozole plus dasatinib group had a progression-free survival of 20.1 months, and the letrozole alone group had a progression-free survival of 9.9 months. Since this is a phase 2 non-comparative parallel type study, this hazard ratio of 0.69 is exploratory. We did look at bone mineral density, and at the start of the study, about a third of patients in each group had a T-score of less than minus 1.5. At the end of the study, when we looked at bone density, only 14% of patients on the letrozole plus dasatinib arm had a T-score less than 1.5, and still about a third of the patients, 32% of the patients on the letrozole arm had a T-score less than 1.5. About 30% of patients in each group received bisphosphonates on this study. So in conclusion, letrozole plus dasatinib had a 71% clinical benefit rate, which was not different from letrozole alone, which had a clinical benefit rate of 66%. In this non-comparative parallel group phase 2 study, letrozole plus dasatinib treated patients had a promising progression-free survival of 20.1 months. Letrozole treated patients had a median progression-free survival of 9.9 months. This data suggests that maybe dasatinib is inhibiting the emergence of acquired resistance to aromatase inhibitor therapy. Other studies have shown that fulvestrant plus exemestane plus dasatinib did not improve progression-free survival in patients with metastatic breast cancer who were previously treated with an aromatase inhibitor, a non-steroidal aromatase inhibitor. Again, suggesting that maybe the benefit from dasatinib would be in patients initially being placed on aromatase inhibitor. Dasatinib at 100 milligrams a day was generally well tolerated with no unexpected toxicities. Dasatinib decreased the incidence of osteopenia on aromatase inhibitor therapy. Putative predictive biomarkers for benefit from dasatinib will be assessed in the patient's archival breast cancer tissues to help inform patient selection for future studies. Thank you.
Caroline Helwig, ASCO Post. So actually your primary endpoint was negative, so it was a clinical benefit rate, but it appears to be a positive study, so maybe Dr. Arteaga would also comment on that, or what would you say about that?
Well, basically, again, this is a phase 2 study. It's a small study. It's not a phase 3 larger study. These patients, there's no placebo in this study. These patients had the option of crossing over. All these things can affect the results. And this is a preliminary exploratory study, and the clinical benefit rate was different, but was the same. But again, this progression-free survival, this doubling, is interesting to us.
So we're seeing that with more and more newer agents, that the response rates may be low and the progression-free survival may be extended. So would you say this is one of those situations?
That could be. I think it's better to say that it's a small study and it's interesting and it will lead to more studies.
So it looked, sorry, this is Crystal Benefit page today. It looked like the difference among the different clinical benefit ratio rate portions was more in a stable disease. Is that correct? That it wasn't in
No, that clinical benefit rate is a calculation of complete responders, partial responders, and the patients with stable disease all combined. We don't separate that out.
Okay, but on the slide you did have them listed separately,
Mm-hmm.
and so among the components it looked like stable disease was where the difference was?
Many patients, that's true, yeah.
Okay, so I guess this goes along with Carolyn's question, but how could that have an impact on, or potentially have an impact on a doubling in progression-free survival? What's going on there?
Yeah, so again, this comes back to the design of this study. It's a small study. It's a phase 2 study, not a big phase 3 study, and there's a crossover in there, and all this stuff can affect the results of the study. So it's hard to explain why the clinical benefit rate, there's nothing we can put our finger on as to tell you why the clinical benefit rate is the same, but the progression-free survival is different.
Okay. Well, maybe you could say something a little bit more about why it's a non-comparative, why have a comparison group?
So that's a statistical term, and it has to do mainly with the size of the population of the patients that we're looking at. It's actually a statistical term.
Wayne Kuzinar from Value-Based Cancer Care. You had a high rate of crossover. It was more than half, right, of the Letrozole group. Did you look to see how that may have affected the difference in PFS, or?
Right, and that's one, no. So that's one of the things that can affect the difference, and that's a problem with doing a crossover study. But I'm sure that does affect the results.
But wouldn't that actually water down the results? I mean, crossover would mean that PFS difference wouldn't be, if it was actually doing that.
Well, so the problem with the crossover studies, you can't really say that. We have to do bigger studies to kind of look at this. Is the bottom line. We need more patients on the study.
Dan Keller, Oncology Times. Was it an intention to treat analysis?
Yes, this was an intent to treat analysis.
All right, then I think that has to be our last. Oh, go ahead.
I have a question for. I have a question also. Can you comment on the? I was stimulated by the results with the bone density because it suggests on-target effect of the SRC inhibitor. And was that also an intent to treat analysis, or was just based on the real, on the patients that did the crossover?
No, that was also an intent to treat analysis, and all patients were included in that analysis as well.
All right, then that is our last comment because we are